Dr. Timothy Adams. I work at UB Surgery here out in Williamsville. We go to multiple hospitals. I travel to Millard Fillmore Suburban, which is literally next door to the office that we are right now, as well as Buffalo General Hospital and Kimball Mercy Hospital. I wear two hats. I am a general surgeon as well as a colorectal surgeon.
Okay, so we're going to focus a little bit more on the colorectal side. So March is Colorectal Cancer Awareness Month. So talk to us about detection of colorectal cancer.
Well, colon and rectal cancer is a very common cancer, not only in America, but in the world. It's in the top 3 or 4 cancers that are diagnosed worldwide, as well as within the United States. If there's a nice thing to be said about a cancer, it's one that has at least a screening tool that allows you to catch it early. Early detection is where we have found our greatest impact on colon cancer. Yes, our treatments have improved, but it's the screenings that are most important. We have recommendations that people get screened anywhere from 45 to 50 years of age or older. The reason why I use those 2 age gaps is because there's new information that is suggesting that colon cancers are being identified at an earlier age, and therefore we're seeing a movement of that age at first colonoscopy shifting downward towards 45. For African Americans, it's been at 45 for quite some time because we've known that the colon cancer prognosis as well as prevalent is a little bit higher in the African American community. The screening is how we identify colon cancers or how we identify colon polyps, which we know lead to colon cancer, and there are several different forms of screenings that we can utilize. The one that's most accurate, the one that gives us the best information and allows us not only to visualize a polyp, but also remove it, is something called a colonoscopy. Most people are nervous about colonoscopies because they're not sure exactly how they get done. They know that the night before you have to drink a lot of stuff that makes you go to the bathroom, and people are very aware of that. They have friends who have had it and tell them all the awful stories with it. But I've had it and it's not that bad. No, it didn't taste great. No, it wasn't fun, but certainly I got through it. But if that wasn't bad enough, then they make an assumption that the colonoscopy, when it's being performed, is some violent procedure that they're screaming through that lasts for an hour, and then you go home and all areas of your body are sore that should never be sore after a procedure. And that couldn't be further from the truth. The night before is a troubling night, and it is a night that's very busy, where you are moving your bowels a lot and you're drinking stuff that doesn't taste great, and you're not able to eat any solid food, so you're sort of hungry as well as a little bit frustrated. But the day of the colonoscopy is really the easy part of the procedure. It only takes about 10 to 20 minutes to perform a colonoscopy. You get sedated for the colonoscopy, so you're not aware of it when it's happening. The sedation is what we call a twilight kind of sedation, so you're not intubated, meaning there's no general anesthesia, there's no tube that's put down your throat that's breathing for you. You're breathing all on your own. Oftentimes, the same dose that makes you comfortable for this sedation is the same dose that makes you sleepy. And that's why most patients will not remember much, and if they do remember something, they just remember taking a very nice nap. But our goal wasn't to put them to sleep. The goal is to make them comfortable. And again, oftentimes those 2 dosages overlap with each other. Once they're resting comfortably, then we're able to perform the colonoscopy, which is a small camera that gets inserted into the anal canal and advanced throughout your entire colon and rectum. By the way, that distance is about 5 feet. The tube itself is only the width of my fingertip, essentially maybe a little bit bigger than that. And the anus is nothing more than a hole. Most people will think that it's exit only, nothing should go in there, and all these other things, but actually it's a hole that it doesn't matter if things go in or out. There's no folds on it, there's no things that can catch on the scope, there's nothing that makes it hurt when we're placing the instrument into the anal canal. As a matter of fact, the reason why we use sedation isn't because we think that the insertion of the camera is going to hurt you. It's during the procedure we have to actually use some air so we can see where we're moving. and it's the air that causes abdominal discomfort. It's almost as if having a really bad night of gas where you want to pass gas, but you can't, and you get that crampy-like feeling. That's what you would sort of feel when doing a colonoscopy if you did not have sedation. Even if there's polyps, which are just little mounds of tissue that we can identify within the inner lining of the colon, removing that doesn't hurt. We don't have pain fibers to feel that. So people will often think when they hear of a biopsy, usually they equate that to some form of pain, but there isn't any pain with that because, again, we just don't have the fibers to sense that. Unfortunately, we do have pain fibers that allow us to sense distension, and that's why we use the sedation. But you get sedated, we insert our camera, we take a good look at the entire colon from beginning to end, and if there's any polyps, we can remove them. The accuracy of the colonoscope is about 95% for identifying these polyps and therefore removing them. Just simply by removing a polyp, we have prevented a case of colon cancer. We know that all colon cancers start out as polyps, but not all polyps develop into colon cancer. So whenever we see a polyp, we remove it because we have no idea, is that going to be the one that's going to convert to a cancer, or is that one that would never change? So they always get removed. Any polyp that we remove, we always send to the pathologist so they can take a look at it under a microscope. Colonoscopies are usually required more than once in a lifetime. I hear that question all the time. Do I need another one? Well, you're only 45 or 50, so hopefully you'll live long enough to need another one. And if you have a life expectancy that fits into a normal life expectancy, then essentially you get a colonoscopy every 10 years if you have no family history of colon cancer and you have no polyps during that procedure yourself. If you have a first-degree relative who has colon cancer, that is either a sibling, brother or sister, or parent, mother, father, then that increases your risk of developing colon cancer. So we would only give you 5 years between colonoscopies, even if you had a perfectly clean colon. If you yourself had colon cancer, then we'd want to screen you every 3 years because your risk of having a recurrent colon cancer is even greater for yourself with that own personal history. So colonoscopies are done more than once in a lifetime, and your family history plays a very significant role on how frequently you get it and even when you get your first one. Because we always say we also say if your family history is significant for colon cancer, then you'll probably need to be screened at an earlier age. So that could be 40 years of age or even 35 years of age. As a matter of fact, if you had a parent who was 35 years of age when they first were diagnosed with colon cancer, then you would get your first screening at 25. So it's always 10 years earlier than the earliest or the youngest person in your family who was diagnosed with colon cancer. So thank goodness we have screenings that allow us to identify these cancers or these polyps before they turn into something sinister. It's just a matter of getting more people out there to do their colonoscopies.
Now, I know that age, kind of plays a part in it, but is there any symptoms that somebody would feel, like if they had polyps or anything like that, that would cause them to maybe come and get a colonoscopy?
The unfortunate part about symptoms is when they develop, it's often at too late of a stage. So that's why you don't really hear us saying to the lay public or to our patient population that, wait until these symptoms develop and then go get your colonoscopy. For screenings, the best time to get a screening is when you feel good. That's the best time to get a screening, and that's what the screening is made for. That means there are tests that we get that we call our diagnostic. So you come in, you complain about something, your shoulder hurts or your abdomen hurts, and then we go, and then we order an appropriate test to make a diagnosis for those symptoms. But screenings are done when you feel good. It doesn't matter if you're having symptoms or no symptoms, and the best time to get that is when you're having no symptoms. Because if you don't have any symptoms, it usually means one of two things. Either you don't have anything, which is great. That's not a useless test then. That just defines the fact that, hey, you've made it to your first benchmark and everything is okay. See you at the next benchmark. Or two, it may mean that you have something, but it's too early for it to cause symptoms. So therefore, it should be easily treatable, regardless if it's a polyp that's too large to be removed with our camera because we can't remove all polyps that way. There is a size limit to what we can do before we would cause more harm than good. Or if it's a cancer, then it's most likely a very early stage cancer that has a very good treatment and prognosis associated with it. But symptoms that can happen when you do have large polyps or colon cancers as they start to progress within your system is that you may notice a change in your bowel habits. So you may go from being constipated to having diarrhea, or you could go in the reverse, having a normal bowel movement to having constipation. You may notice a change in shape of your stools, where they might start to become thin, like pencils, as opposed to a more bulky or a larger stool formation that you might be used to seeing. You may notice a change in color. So it could be bright red because tumors can bleed. So can large polyps. They can bleed, changing the color of your stool to a more of a reddish color. Old blood that sits around in your system can turn your stools black. So you may notice that your stools are black. And then you have other sort of symptoms that are sort of generic for almost anything that's related to the abdomen. You may have nausea or vomiting, or decreases in appetite, decreases in weight. So if you notice any of those changes, you always want to speak to your primary care doctor about those changes so they can listen, understand, and order the appropriate test for you.
And then, so I want to just kind of talk a little bit about needing to get that colonoscopy. Do you have to have a referral from your primary care doctor? Can you just kind of show up at the office? How does that process work?
Way back when, probably 5 years ago, you did need that referral, but the insurance companies have made changes to what their regulations are and what the rules are. And so now you don't need a referral at all. You just need to be of the right age, or if you're having symptoms, you just need to have the right symptoms. If you happen to know a colorectal surgeon or a GI doc in your area, then yes, you can just call them up and say, I'd like to arrange an appointment. They would see you and, again, make the proper recommendations for you as it relates to getting you that colonoscopy. But you no longer need to go through your primary care doctor. You don't even really need to come in and meet your GI doc or your colorectal doc prior to the colonoscopy either. We used to do that. We would bring the patients into the office just so as an introduction and then do our colonoscopy, but quite honestly, that was getting too costly for the patient. Many patients did not like that just simply because it was costing them extra money, and many people just don't have an extra $20 or $50 or $80 sitting around just to say hi and then see you at the colonoscopy kind of thing. So we don't really do that introduction unless patients want to. Every now and then we'll still have a patient who wants to come in. I want to see you first before you go back there, you know. But for the most part, patients will meet me at the endoscopy suite, at which time I will ask them what's been going on, how have they been doing, making sure there's no other symptoms that I need to be aware of before we get started on our colonoscopy.
Okay, and then just kind of final question for people who are watching this video, how can they get in touch with this office to maybe schedule a colonoscopy?
Absolutely. So again, we're UB Surgery, but the phone number to this office is area code 716-636-9004. We have offices in Kenmore, West Seneca, and Williamsville, and we'd be happy to see you at any of those places. We do colonoscopies in Williamsville as well as Orchard Park / West Seneca area, and so we'd have the ability to see you and perform your procedure at different areas of the city as well.